We've already discussed enough on basics of lung anatomy, embryology, and its correlation with your congenital pulmonary malformations in the last video. But in this particular section, we are going to see the most important and little bit relatively more and more interesting compared to the previous video, that is the basics of lung physiology, which forms the core basic for your understanding of ventilators and respiratory failure in the future. So let us kick it on. So the first thing, in the base of lung physiology, the most important thing what we have to discuss is the oxygenation. Because we are going to discuss a lot of topics like oxygenation, ventilation, perfusion. Then we also be discussing on mechanics of breathing. Then also be discussing on the work of breathing and time constant. So these are the things I'm going to discuss in this particular section. But with a lot of applied aspects also I'm going to discuss. But let us first finish off the oxygenation part. Oxygenation has a lot of clinical relevance as well. So that's why I want to do this first. So like the basic function of any alveoli is the gas exchange. So this is the basic alveolar unit. So in this is going to be the capillary, and that is going to the base membrane. And the basic function of any alveolar unit is going to be the gas exchange. O2 is going to go into the capillaries and CO2 is going to go out of the capillaries, which will be exhaled into the atmosphere. This is the basic function naturally. So gas exchange, right? Okay. So having said about the gas exchange, how the oxygenation process happens. So remember, these gases, that oxygen moving inside or carbon dioxide moving outside, all these things are going to be based upon a process called diffusion. All this is going to happen through a process called diffusion. So this diffusion of gases is actually governed by a lot of laws. A lot of rules are there which governs this diffusion. The most important of all is the Fick's law. The most important of all this is the Fick's law. This is the Fick's law of diffusion. So the Fick's law of diffusion states very simple things, that the rate of diffusion, which can be denoted by D in my example, the rate of diffusion is equal to the surface area of the diffusing membrane multiplied by the difference in the partial pressure of the gas between the either side of the diffusing membrane multiplied by a solubility coefficient called K. It's a constant value for a particular gas divided by T, which is the thickness of the gas, thickness of the membrane. So first let us see what is the importance of the thickness of the membrane. You know very well, whenever the thickness of the membrane is going to increase, your diffusion of the gas is going to decrease. There's no doubt about that. Thickness is going to increase, definitely diffusion is going to decrease, because they are inversely proportional, denominator and that is on the top. So you can easily reduce it. So what is a single most important example where you can tell thickness is increasing because of the diffusion is reducing? The characteristic example which I give you for this, for this thickness related explanation is your interstitial lung disease. Let us see what's going to happen here. So this is the alveolar capillaries and this is the basement membrane, and let us assume this is the interstitial area. This is the interstitium. Let us assume for some reason the interstitium is getting thickened, which means interstitium is becoming thicker and thicker and thicker, and it is not allowing the gases to move properly. So here what is essentially happening is the thickness of the barrier is really increased. The thickness of the diffusing membrane is increased because of thickening of the interstitium due to accumulation of some substance in the interstitium. It could be a fibrosis, it could be accumulation of a fibrotic substance in idiopathic interstitial pneumonias, or it could be like water in the form of a pulmonary edema, or it could be anything. So anything that increases the thickness of the interstitial membrane is going to reduce the diffusion. So one classical example where you will encounter something called a diffusion limitation is interstitial lung disease, ILD. Okay, fine, all right. So now we'll move on to the surface area. You know very well, when the surface area is going to decrease, definitely your diffusion is going to decrease. The reason, again, it's directly proportional, so definitely that is what mathematically by this formula it should happen. So let us assume one important example where the alveolar hyperinflated. Wait on. So I am telling alveoli is hyperinflated, yes, but still the diffusion is restricted and the surface area is reduced. How is that possible? Yes, it is possible. How is going to be possible is because in a condition called emphysema. This is a characteristic example of something called diffusion limitation once again, because the surface area is reduced. You all know that emphysema is a condition that produces hyperinflation. Yes, that is true. This is not wrong at all. It is going to produce hyperinflation, but still, how come the patient is having a reduced surface area? How is this possible? It is because in emphysema patients, lot of the areas in the alveoli are damaged and they are scarred. So they are not functionally active, which means the effective surface area for gas exchange is actually less in emphysema. Why these areas are scarred in emphysema? Because of the release of elastasis. So you have smoke, cigarette smoke. This is going to activate the macrophages to release the elastasis. So you are going to increase the macrophage elastasis. At the same time, they are also going to increase the neutrophil elastasis in the site of inflammation, that is the alveoli. They are also going to increase the neutrophil elastasis. So what is really going to happen here is, because they release this elastasis, because the cigarette smoke attracts these macrophages and neutrophils to release this elastasis, because they produce this elastasis, what you are going to get is, you are going to damage the elastin molecules. This elastin molecules, because they are damaged, that is the reason why emphysema lung is going to behave like a plastic and polythene cover. They expand, but even if you release the pressure, they are not going to come back, recoiling, which means because of the reduced elastins, there will be reduced recoil. That is the reason why they are hyperinflated in the first place. That is due to damage to the elastin fibers. This smoke doesn't only activate the neutrophil to release the elastasis, they also activate the macrophages and the neutrophils to release other damaging enzymes that are going to damage your alveolar surface. So, which means your effective surface area of the alveoli is going to be very, very less. Very important point. So, that is the reason why, even though in emphysema the lung is hyperinflated, the effective surface area for diffusion is actually low. That is also the main reason why your diffusion is restricted. So, I can tell one more example for a diffusion limitation, that is emphysema. So, in the entire world, if somebody asks you what are the examples of diffusion limitation, please tell them ILD and emphysema as the first two topmost examples. Why this is important? Because in the later on, I will be telling one important thing. Whenever the patient is having a prominent diffusion limitation related problem, the most important clinical feature that you are going to encounter is exercise-induced hypoxemia. Exercise-induced hypoxemia. And many of these patients will maintain normal oxygen, partial pressure in the arteries at rest. At rest, they won't have any problem. But the moment they start walking, the moment they start just go to the bathroom and you see the saturation will drop and the PaO2 will drop. So that is called exercise-induced hypoxemia or exercise-induced desaturation. Whenever in exam you get this word, it 100% goes towards diffusion limitation. And it's going to, whenever you call diffusion limitation, the disease that are classically associated with it is ILD and emphysema. You have to be very, very clear about that. So the two basic diseases that cause diffusion restriction and diffusion limitation. Your ILD is a restrictive lung disease that produces diffusion limitation. And typically emphysema is an obstructive lung disease that produces diffusion limitation. So these are various spectrums, but still you have to know that. But anyway, what is the importance of this P1 minus P2? Not that much important in your pulmonary medicine, but still this P1 minus P2 means you have a surface P1 and a surface P2, like on the side P2, this is the diffusing surface, diffusing membrane. So diffusion acts by typical concentration gradient related principle. Suppose if if the concentration of the gas or the partial pressure of the gas is very high here and the partial pressure of the gas is low here, automatically your diffusion is going to happen from a region of higher partial pressure to the region of lower partial pressure, just to equilibrate on both sides of the membrane. That is how diffusion works. It's like osmosis for the fluid. Simple. So that's how it's going to work. So unless until the concentrations become equal or the partial pressures become equal on both sides. So that is how diffusion works. So this is really important because in one way, in the alveoli, very well, your concentration of gas is going to be always higher. concentration of oxygen, for example, this called, whenever you put a capital A, it means alveolar concentration. PaO2 is always higher compared to what you see in the capillaries, that is PaO2, which is always lower, and PaO2 must be always higher. Then only your diffusion can happen from alveoli towards the capillaries. Suppose if PaO2 is low and PaO2, your alveolar carbon dioxide is higher, then, if your arterial oxygen is higher than the alveolar oxygen, then what is going to happen? Your oxygen will start diffusing into the atmosphere. Then that situation never happens in a physiologically healthy person. And always PaO2 will be lower compared to that of the alveolar oxygen. So that is the reason why diffusion of oxygen is always through only one route, that is from alveoli towards the capillaries. It doesn't happen the other way around. So this is also important because this is the one that determines the movement of the oxygen into the blood and not outside into the atmosphere. But carbon dioxide is reverse, because the carbon dioxide here in the alveoli is always lower compared to the carbon dioxide in the blood, because during metabolism the oxygen is extracted and carbon dioxide released, which means the blood that is coming into the lungs will be rich in carbon dioxide but low in oxygen. So they suck in the oxygen and push the carbon dioxide out very easily by a process called diffusion. That is because of this P1 minus P2 difference. Clear? So this is one important thing that you have to understand. Okay, you have understood all these things. So now the final say is on the diffusion coefficient, that's called K. I told you this is a constant called diffusion coefficient. Is it really important, this diffusion coefficient? Yes, but even though it's a constant, in what way it's going to affect? In one particular way, it will definitely affect you. That is, the K, diffusion coefficient of a particular gas, is a constant for a gas, for a given gas. It might vary between gases, but it's constant for a given gas. It is usually given by the formula called solubility divided by square root of molecular weight, which means this diffusion coefficient can also be rewritten as something called solubility coefficient. It can also be rewritten as something called a solubility coefficient. So which means it's given by the formula solubility by square root of molecular weight. So according to the equation, which gas? We have three gases: carbon dioxide, oxygen, nitrogen. Which is going to have the maximum solubility? It is the carbon dioxide that is going to have the highest solubility. Okay, so which means it is going to have 20 times more solubility than oxygen, and oxygen in turn is going to have more solubility than nitrogen. So among the commonly inhaled gases, the gas which has the lowest solubility is nitrogen, and the gas which has the highest solubility is carbon dioxide across the diffusion membrane. Clear? So that is the reason, because this is important to understand, because one particular type of respiratory failure is there, that is called a type 1 respiratory failure. So what happens in a type 1 respiratory failure? You will encounter something called a hypoxemia. This is the primary event in type 1 respiratory failure, which means you are going to encounter hypoxemia. This hypoxemia is going to stimulate the chemoreceptors, and it's going to accelerate the respiratory drive, which means patient's respiratory rate will increase and patient's depth of respiration also will increase, which means patient will start hyperventilating. Once the patient starts hyperventilating, you are going to wash out carbon dioxide, and this low CO2 with low PaO2 is the classical of a type 1 respiratory failure, and this is what will be given in many of the textbooks as a definition of type 1 respiratory failure, which is also referred to as something called a hypoxemic respiratory failure. Why it is called a hypoxemic respiratory failure? Because the primary triggering event is the hypoxemia, that is low levels of oxygen in the blood, low level of dissolved oxygen in the blood. That is the primary thing that causes this respiratory failure. So, but you might asking me, first of all, why the patient is going for this excessive respiratory rate? That is in response to this hypoxemia, because at least by increasing the respiratory rate, by increasing the minute ventilation and producing hyperventilation, they can somehow take in more oxygen to compensate for the hypoxemia. But to be honest, you might, for example, let us assume initially the patient, what is the normal PaO2? Let me tell the normal values. Normal PaO2 is maybe 75 to 100 millimeters of mercury, and normal PaCO2 is 36 to 44 or 35 to 45 millimeters of mercury. So this is the normal value, which we'll discuss in detail later on. But what we are trying to do is, since the blood is having, so let me tell you in detail, since the blood is having low PaO2, since the blood is having low partial pressure of oxygen, actually it stimulates the respiratory drive. So you are increasing the respiratory rate, which means this is in an attempt to suck in more and more oxygen, and that is to normalize the PaO2. That is the reason why the respiratory rate is increased. But what is going to happen is, the act of breathing is not only to suck the oxygen inside, this is also going to push the carbon dioxide outside. As I told you, the carbon dioxide's solubility is going to be more than that of the solubility of the oxygen. So which means the movement of carbon dioxide, the movement of this carbon dioxide is going to increase more than the movement of the oxygen inside. So even before you normalize this PaO2, the PaCO2 will drop dramatically, which means it's very difficult to normalize the PaO2 by producing excessive respiration. Even though to an extent, see, this is oxygen is really, really important. To an extent, you somehow try to increase the PaO2, but rising the PaO2 is not that easy because the oxygen solubility is actually very less. How much ever you faster you breathe, depending on the severity of the disease, your PaO2 may be normalized or PaO2 may not normalize. But immediately your PaCO2 will drop. Why? Because the solubility of carbon dioxide is so high, so relatively, the more faster you breathe, the faster you exhale PaCO2. But whether or not you will normalize the PaO2 or not, it doesn't matter, but you will definitely lower the PaCO2. So what do you mean? So what happens really here is, as a result of reduced PaO2, you are going to hyperventilate. That will, definitely lower the PaCO2, but it might it might normalize the PaO2, or still the PaO2 might be decreased depending on what is the underlying physiology. What is the underlying pathology. But definitely your PaCO2 levels will drop, and this is due to the excessive solubility of the carbon dioxide. This is the idea. So the entire type 1 respiratory failure can be understood by understanding the solubility coefficient, because why PaCO2 is dropping in your type 1 respiratory failure. Clear? That is just because the solubility is so high for the carbon dioxide. So you can understand, I feel. So this is the importance of the solubility coefficient. That is the reason why PaCO2 is dropping in type 1 respiratory failure. At the same time, when only one thing, with this example, you can also tell one important thing. The major thing that determines the CO2 level in the body, PaCO2 in the body, that is carbon dioxide levels in the body, is the ventilation. Remember, oxygen in the body is determined by so many factors, by ventilation, by perfusion, by diffusion. So many things are determining the oxygen levels, that is PaO2 levels in the blood. But the one and only thing that will determine the carbon dioxide levels in the blood is your ventilation. The most important thing. The more you breathe, the more CO2 you will wash out. The less you breathe, more CO2 you will accumulate in the blood. That's it. So very, 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 very important. Carbon dioxide is typically a ventilation dependent gas. But oxygen is dependent on so many things. Ventilation, perfusion, diffusion, so many things your carbon dioxide is dependent on. Oxygen is dependent on. But carbon dioxide purely dependent on ventilation only. That is again because the solubility factor which I told you, that is the only thing that determines your carbon dioxide levels. Okay, fine. We have understood all these things in the first place. What is the importance of the Fick's law, and each and every component we have dissected in the Fick's law. But one very important thing we have to understand is about the effects of the altitude on oxygenation. So what is the effect of altitude on oxygenation? Let us assume a patient who's not a patient, maybe a person who's at the sea level. So let us assume this is a sea level or normal ground level. What is going to be the partial pressure of atmosphere? Total partial pressure of the atmosphere, it is going to be 760 millimeters of mercury. This is a very common thing. So let us assume a patient is moving into some mountain somewhere. So probably is now in the high altitude. So what happens here? Definitely, it's a very easy thing to understand that his partial pressure of oxygen is going to drop. Definitely, his amount of oxygen is going to breathe at this level is going to drop definitely. But what is the mechanism behind that? You all will be thinking, for example, what is the fraction of inspired oxygen here? It is 21%. But it's a common mistake to understand that the fraction of inspired oxygen at this level reduces. Actually, it's not. It's still the same 21% even at high altitude. For example, astonishingly, there is one fact which I will tell you. Even if you go to the International Space Station, the FiO2 still is around 19 to 21% only. I mean, really, the concentration of oxygen never drops even how much ever you go above the atmosphere unless and until you enter the real outer space. Apart from that, it's not possible to reduce the concentration of oxygen. By minor means, it might reduce, but not there is no major decline. I mean, you might ask me, ISS is on the top. No, ISS is in the low Earth orbit only. Only geostationary satellites, which are important for the GPS and television, are orbiting at 36,000 kilometers. And above the sea level. But your ISS is only orbiting at 400 kilometers above the sea level. That is very, very close by comparatively. It's in the low Earth orbit. In the night also, you can see ISS many times if you look carefully. That is going in this thing. So, which means it's in low Earth orbit, which means there is some atmosphere in the ISS, even though it's not sufficient to breathe there. Which means there also the concentration of oxygen is going to be in somewhere 19-20% only, not much less. Which means this is not going to change depending on the altitude that you commonly encounter. So, what is going to reduce in high altitude is the atmospheric pressure. The P atmosphere itself is going to reduce. So, what is going to happen? So, suppose here, what will be the partial pressure of oxygen? Here, the partial pressure of oxygen is approximately 160 millimeters of mercury. That is the partial pressure of oxygen here. Why it is 160 millimeters of mercury? Because 21% of this 760 is going to be 160. How you have calculated this 21% of 760? Who gave me the rights to calculate the 21% of 760? Because there is a scientist called Dalton who gave me the permission. This is what we refer to as something called Dalton's law, which tells you the pressure of total pressure exerted by a gaseous mixture is equal to the sum of the pressure of individual gases. As simple as that. So, which means I can clearly tell the total pressure of the gaseous mixture, which means the atmosphere has a lot of gases. For example, let us assume oxygen. Let us assume it has nitrogen, it has carbon dioxide, it has a lot of inert gases. According to Dalton's law, the total pressure exerted by the gaseous mixture is equal to the sum of the partial pressure of individual gases. I mean, I left the water vapor here, but anyway, forgive me. So, this is what is going to happen, which means since Dalton's law is telling individual gases, when you add them together, you are going to get the total partial pressure of the mixture, that is the atmospheric pressure. I can tell that 760 millimeters of mercury in the 21% is contributed by the oxygen. So, which will be equal to 760 multiplied by 21 by 100, you are going to get somewhere around 159. I am writing as 159 or 160 millimeters of mercury, and that's what you are going to get. So, that is the partial pressure of oxygen at the sea level, at the ground level. Clear? So, now when you move to the high altitude, your partial pressure of atmosphere, the atmospheric pressure itself is the barometric pressure in the environment itself is reducing because the density of the air molecules reduces obviously, because in the ground you have maximum gravity near the ground. That's why the density of air molecules are maximum because they are pulled towards the ground. As you move higher and higher, because of the lower gravity, you are going to have a reduced density of air molecules, so that you have to reduce the partial pressure of atmosphere. You will be having reduced partial pressure of atmosphere. So, because the atmospheric pressure itself is dropping, for example, let us assume at this particular altitude, we are assuming that the atmospheric pressure is only 500 instead of 760. But let us assume there is no change in the fraction of inspired oxygen, still it is 21% only. Now we are going to have only 105 millimeters of mercury of your partial pressure of oxygen in the atmosphere, which means actually you are breathing oxygen at low partial pressures here compared to what you are on the ground. So, if you are on the ground, you are breathing at oxygen at a higher partial pressure compared to the high altitude. At this point, you are breathing only 105. The more and more you go up and up and up, the more and more you are going to have low atmospheric pressure. Suppose if you are going to a still higher altitude like Everest, which is at 8,840 meters above the sea level, which means it's around 28 to 30,000 feet above the sea level, which is actually the height of the standard aircraft. That your commercial planes, your domestic aircraft, which actually, like standard aeroplanes fly at this altitude only, 30 to 35,000 feet, which is actually the height of the Mount Everest. If you go at that height, definitely, the partial pressure of the atmosphere itself will be somewhere around 35 millimeters of mercury only. This will be the partial pressure of the atmosphere itself. In that, the partial pressure of oxygen will be 21% of this, your 35, which is just I feel it is around 7 millimeters of mercury. That's it. This is that, the partial pressure of oxygen that you will be breathing. Which means here what you are breathing is 160, but when you go to Everest, what you are breathing is only 7 millimeters of mercury of partial pressure of oxygen, which is going to result in instantaneous death and coma. No matter whether you carry, whatever acclimatization you encounter, this is not possible to survive here. You cannot survive with 7 millimeters of mercury oxygen, partial pressure. You need to carry your oxygen cylinders and you have to wear the mask and go to the Everest, or at such high altitude, it's impossible to survive without, proper pressurization and proper oxygen cylinders and masks. So this is the impact of your, high altitude and oxygenation. As you go up, the most important thing to understand is your concentration doesn't decrease that much, but your partial pressure of the atmosphere itself will decrease, which will drastically affect the partial pressure of the inspired oxygen molecule. Clear? So now, according, you can apply the Dalton's law very simply. So what will be the partial pressure of inspired gases at sea level? For example, at sea level, what will be the partial pressure of molecules? For example, nitrogen, I can tell it is going to be 79%, and oxygen is 21%, and water vapor it is around 0.04%, and carbon dioxide is going to be 0.004%. If I going to equate this into the partial pressures, individual gases partial pressures, clear? So it is going to, somewhere around 595 to 600 millimeters of mercury. I'm telling average. I'm a medical student. Definitely, I want averages rather than a fixed value. I'm not an engineering student. And here it's going to be somewhere around 160 millimeters of mercury, which we have derived already. Here it's going to be somewhere around 3 millimeters of mercury. Here it will be around 0.3 millimeters of mercury. So this is the approximate partial pressures at sea level of different gases. Total will give rise to the total atmospheric pressure that will come around approximately 760 millimeters of mercury. This is what Dalton's law is telling. The sum of partial pressure of individual gases is equal to the partial pressure exerted by a gaseous mixture. As simple as that. Remember, even if you are breathing this much nitrogen at sea level, still nitrogen is not going to enter into the body, or it's not going to have any effect even if it enters the blood. Why? Because of its very, very poor solubility. Nitrogen has an extremely poor solubility. That is the reason, first of all, it doesn't enter the alveolar membrane. Only carbon dioxide and oxygen predominantly enters. So how beautifully nature has, evolved. Humans are evolved along with the nature. So because nitrogen is insoluble gas, it's not going to have a good solubility. So that is the reason why even we breathe this much amount of nitrogen, it's not going to cause any problem to us. But this is a problem in a different disease called Caisson disease, which we are going to discuss in a different law, not in this. Clear? So this is what we're going to find it out. Before that, going into that, one more thing I want to tell you, one more important aspect of this oxygenation is important. So let us assume this is the alveolar capillaries and this is the base membrane. All right. So you are breathing, let us assume this is sea level. Let us first see an uncomplicated patient. You have a sea level patient at sea level who's breathing room air. So what will be the partial pressure of oxygen, of the atmospheric oxygen? It's going to be, I told you, 160 millimeters of mercury. This is what is taken in by the patient. But the partial pressure of oxygen that is present in the alveoli, alveoli means big A, always, bigger A is alveoli. What will be the partial pressure? Is it going to be the same 160 or it's going to be less? Definitely less. Partial pressure of the alveoli, partial pressure of the oxygen in the alveoli is not going to be the same. Definitely it will be less than what is present in the your atmosphere. Which means is someone is going to take this oxygen, suck this oxygen while coming inside the body magically? Answer is no. It's not something that sucks the oxygen inside. While coming into the conducting airways, it's just because of the contamination by other gases. For example, you have two important gases that are going to contaminate, especially in the conducting airways, the water vapor that is going to come out through your body heat that is generating this water vapor. So that is going to contaminate, number one, your oxygen that is coming in. Second, it is the carbon dioxide that is coming, because of gas exchange, because in the previous gas exchange, you would have, a lot of carbon dioxide have moved into the alveoli. So that oxygen is going to mix with the carbon dioxide and that is going to reduce the actual concentration of the oxygen that is inspired. For example, by approximate reasons, if FiO2 is 21%, but the FiO2 here you will get is only approximately 14%. That is because of the contamination by other gases, which will effectively reduce the concentration. The moment you reduce the concentration by Dalton's law, again you have to reduce the partial pressure of the particular gas. Clear? Because concentration is getting reduced. So, I mean, this looks a little bit clumsy. Let us make it more clear. So, what will be the partial pressure of oxygen? Ideally, it will be around 100. 100 to 110 will be the partial pressure of oxygen in the alveoli. But what is the reason for this drop in the 50? I told you that is due to contamination by the other gases, especially your water vapor and the carbon dioxide. So, which means, is this constant? So, if I breathe at a higher, maybe the inspired oxygen is having 760 millimeters of mercury oxygen. Yes, possible. If you connect to a ventilator and give 100% oxygen, which means all the atmospheric pressure is full of oxygen only, 100% oxygen means no other air contamination, 760 millimeters you breathe in. So, in that case, obviously this partial pressure of alveolar oxygen will increase. So, you cannot use this kind of, imaginary games and all. So, let us become serious and put a very important formula that is called an alveolar gas equation. What do you mean by this alveolar gas equation? This alveolar gas equation is designed to find out the partial pressure of alveolar oxygen. Clear? Partial pressure of alveolar oxygen, not the arterial oxygen. Arterial oxygen we can find out through simple ABG. We don't want any complications. So, alveolar oxygen, how we are going to find out? So, this equation tells that the fraction of inspired oxygen multiplied by partial pressure of atmosphere minus partial pressure of water vapor inside the body, that is acting as a contaminant inside the conducting airways, minus your partial pressure of carbon dioxide in the arteries divided by the respiratory quotient. This is the actual formula for detecting the PaO2. Because I told you already, I don't want to derive the formula, it's easy to derive, not a big deal, but I just want to tell the respiratory quotient is the one that determines the carbon dioxide, and carbon dioxide is one major contaminant here. That's why the equation contains carbon dioxide. At the same time, another major contaminant I told you is water vapor. That is why you have water vapor in the equation also. Now you can understand. So why you are putting a minus symbol for all these things? Because effectively by equation wise you have to derive it. But anyways, these are things that play a major role in reducing the partial pressure of oxygen in the alveoli compared to that of the air in the atmosphere. Clear? So this FiO2 is a variable because currently many patients in the ICU and the emergency are treated with oxygen masks which deliver a variable amount of FiO2. It's not only 21%, it can be 40, it can be 60, it can be even go up to 100. So depending on the device you are using. So FiO2 is variable, so I am not going to change FiO2. But typically majority of the ICUs and hospitals are located in the low altitude, in the sense in the sea level. So let us, and don't complicate it and put 760 here, but remember this formula has to be put according to this. If you are living in a high altitude, like in some hill station, if you are setting up a hospital, then this will change for sure. Clear? So minus, this is a constant, this water vapor pressure is 47 millimeters of mercury inside the conducting airway, so we are going to put that. Minus PaCO2, again it's a variable depending on patient's ventilatory status. I told you the most important thing that determines the carbon dioxide levels in the arteries and the body is your ventilatory status. And you can put respiratory quotient as 0.8. This is an average if you take a carbohydrate and a fat and a protein mixed diet. So what is the respiratory quotient? You know, per molecule of O2 consumed, how much molecule of CO2 you are producing. That is, respiratory quotient. For carbohydrates, it is 1 molecule of O2 consumed and 1 molecule of CO2 produced. So this is, ratio is 1. Respiratory quotient is 1. For fats, it is 0.6. For a mixed diet, you can take it as 0.8 because nobody takes a pure carbohydrate or pure fat unless until they are on a typical paleo-based diet or any other weird diets, but generally we take it as 0.8. So I can rewrite the equation. A patient who is living at sea level, I can put 713 multiplied by fraction of inspired oxygen minus PaCO2 by 0.8. This inspired oxygen you know very well because you are going to get from the ventilator readings or from the mask which you are using or the device, oxygen delivery device you are using, that itself will tell you what is the fraction of inspired oxygen in your hospital. And your PaCO2 is also easy because you are going to find out easily through ABG analysis. Very simple. So other values you are constant. So very easy to find out this partial pressure of alveolar oxygen. This is what we refer to as something called a famous alveolar gas equation, which is to find out the partial pressure of alveolar oxygen. Clear? So now you know all this concept. So why I told you with so much of pain? So it is to tell you that partial pressure of alveolar oxygen is actually lesser compared to what you breathe in. But what you actually breathe in is less, but what it goes inside is even more less, which means partial pressure of arterial oxygen is even more lesser than what you see, even more lesser than what you see in the alveoli. Why it has to be? Because this, if you take this surface as P1 and this surface as P2, this always has to be more, then only oxygen will diffuse into the other side of the barrier. If here in alveoli, if the partial pressure is low, in artery the partial pressure of oxygen is high, it's impossible, because that will result in movement of your oxygen towards the atmosphere. That is not going to be the genuine thing in the first place. That cannot happen. That is not physiology. So always this PaO2 will be lower only by your Fick's law. It has to be lower, and it will be lower. But what if, what you can deduce by this PaO2 being lower than the partial pressure of the alveolar oxygen? You can deduce that you can imagine that this has a wastage, which means some oxygen has to be wasted. Clear? Naturally itself it has to be wasted to maintain this gradient, so that oxygen can keep on diffusing to the blood and not from blood to the alveoli and to the outside. Clear? So this wastage is actually needed to an extent. Small amount of wastage is needed, and how you can calculate how much is getting wasted or what is the wastage is by calculating the difference between the partial pressure of alveolar oxygen and partial pressure of arterial oxygen. So if you have this difference, this is also referred to as something called alveolar arterial oxygen gradient, which is a very, very, very important number. Alveolar and oxygen gradient. So which means there is a limit of how much you can waste physiologically. So how much you can waste? Ideally speaking, normal wastage should be less than 12, which means the alveolar arterial oxygen gradient must be less than 12, which means the difference between them should be less than 12, not more than that. For example, in a typical PaO2, if you ask me, normal PaO2, it is somewhere between 75 to 100 millimeters of mercury. That is the ideal normal PaO2. For example, if you in PaO2, if it's 100 and 100, if PaO2 is 100, then your P small a O2 will be around 95 in a normal physiological patient, which means the wastage is only 5, which is really normal. So which means it is less than 12. Or the normal wastage, that is normal AA gradient, can also be given by the formula, something called age divided by 4 plus 4. This is also formula. This is also a formula that will tell you a normal AA gradient. Or you can tell age multiplied by 0.3. So this also will give the normal AA gradient. There are multiple formulas for that, but some books will give you less than 30. That also some books will give you. But lot of formulas are there to detect the normal AA gradient. But I will always tell, for simplistic purpose, keep it as less than 12. Why I tell less than 12 is your anion gap normal also is less than 12. AA gradient normal is also less than 12, because both these things are, you are going to couple it in the acid-base balance, which we will discuss in a separate video. It's not going to come under pulmonary medicine at all. Clear? Because ABG is something where you can integrate pulmonary medicine, you can integrate nephrology, you can integrate cardiology, you can integrate CNS, lot of things you can integrate in the ABG. So you need a separate discussion on ABG, not in this right now. So for that meaning only, I will usually ask the students to remember as less than 12, because you can remember along with the anion gap, which is also normal, is less than 12. Clear? So this is the normal AA gradient. Wastage should be less than 12, not more than that for sure. Fine. So now you have the AA gradient. So how will you find out the AA gradient? Which means you have the alveolar gas equation. With that, you are going to find out the partial pressure of the alveolar oxygen. Minus, you have the PaO2. PaO2 you are going to easily get from the acid-base analysis, ABG values. So easy to find out the AA gradient. This is a real important AA gradient. Why? Because I told you there is a permissible level of wastage, that is less than 12. That amount of wastage is actually permissible, and it's physiological, and it's needed for pushing the oxygen into the capillaries from the alveoli. But what if I am telling the AA gradient is increased? What if there is increased AA gradient? Which means AA gradient, for example, supposedly if it's 75 or 100, let us assume this 75 in this example. Which means what I am trying to tell is, there is some PaO2. Let us assume it is maybe 100 is the PaO2. Now I am telling the PaO2 is only 25, which is actually quite, a patient will die, like faster with this PaO2 and all, because it is incompatible with life for a long time. They cannot live, because PaO2 of 25 means it is much lesser than the normal value of 75 to 100. So you cannot live with this arterial oxygen. This is severe hypoxemia, definitely. So what is the wastage here? If you see, it is almost 75. 100 minus 25. So that is what is depicted by the 75 A grade. So what is happening here? Which means there is increased wastage. What do you mean by increased wastage? Which means there is something in this area that is preventing the oxygen from moving inside the, capillaries from the alveoli. So what is preventing? It could be low ventilation, it could be low diffusion, or it could be even a low perfusion. We will discuss separately in the cause of type 1 respiratory failure. So whenever you have a patient with hypoxemia who is struggling to breathe, see the A gradient first. So whenever the patient is having a suspect respiratory failure, the first thing we'll be doing is seeing the A gradient, AaO2 gradient. So if the AaO2 gradient is increased, which means definitely there is some problem in the movement of the oxygen into this thing. So which means it's more than what you can expect. Like less than 12 is normal, that is actually needed. But if it's more than 12, like 50, 60, 100, sometimes it can be in the 200s also. So if that much increase A grade means definitely there is some problem in the movement of oxygen into the blood. Definitely that must be due to some problem in that diffusion area, or some other problem in the perfusion of the blood. Something is happening, so which is typical of a type 1 respiratory failure. Clear? So now I am telling the patient is having hypoxemia but a normal A gradient. So tell me one example where I can have a normal A gradient. What do you mean by normal A gradient? So I am telling, okay, let us give a very practical example. Okay, just easy for understanding. I am telling what I mean by A gradient. The wastage is normal. Let us assume it's only 5. But there is hypoxemia. I gave a condition, there is hypoxemia, which means PaO2 is very less. But here the PaO2, let us assume it's only 30. Let us see. It's only 30. Just for understanding sake, I'm telling you, this very severe hypoxemia patient is not compatible with life. Anyway, PaO2 is only 30 in this example. I told you A gradient is normal, which means you know very well PaO2 minus P small aO2 is equal to 5 in this example. You know the P small aO2, that is, we have already found out, that is 30 is equal to 5. That's a normal A gradient, which means PaO2 is equal to 35 millimeters of mercury. Which means here the PaO2, that is the capital aO2, that is the alveolar oxygen itself, is only 35. So what should be the normal alveolar oxygen? Normally at physiological limits itself, it must be somewhere around, you can see it is 100 to 110. But here it is only 35. What could be the cause? Which means what I am trying to tell is, here the exchange is okay. The exchange is okay, it is fine. There is no problem in the diffusion barrier. But the amount of alveolar oxygen that is present here itself is reduced. That is the reason why, since the incoming itself is reduced, what is going into the capillaries is also reduced, but there is actually no much wastage happening. What efficiently it is moving across the barrier, but incoming itself is very less. So in what condition? Tell me one condition logically where incoming oxygen itself is very less, so that the alveolar partial pressure of oxygen will be less. Very easy example, you can tell in high altitude. Typical example, even though in physiology we will give this example as a high altitude, but like in clinical reasons I don't give high altitude as an example. You can tell conditions which is going to reduce the environmental oxygen. For example, a patient is on ventilator, the oxygen cylinder guy has forgot to change the cylinder. This happens very commonly in low resource settings, like where they don't have any like proper oxygen chamber, and they're still dependent on the cylinders to change. If he forgot to change the cylinder and he slept in the night, the patient is going to inspire air that is going to contain a very low fraction of inspired oxygen, and that is going to decrease the alveolar oxygen, because the environmental oxygen itself is very less. So that is the one condition that mimics the high altitude. But anyway, physiologically I can tell high altitude where the partial pressure of oxygen in the environment, that is in the atmosphere itself, is reduced, which means outside itself is reduced. So whatever is going to come in also will be reduced, and whatever is going to stay in the alveoli is also reduced. So whatever it's moving inside is okay. Whatever is coming, it's going properly, but because this is decreased, this also will be decreased. So that is the understanding I'm going to tell whenever the A gradient is normal. So whenever A gradient is normal means I'm going to tell low FiO2 states, or bar I can tell high altitude where the atmospheric pressure is low. Clear? Any one of the conditions. The first one is, this low FiO2 state is very, very common in ventilator settings, especially in hospital settings, which is actually a, really a negligence only to forgetting to change the oxygen cylinder and all. Number two. Second, what is going to happen is, supposedly, if the patient is not breathing, let us assume second example. This example, it's very important to understand. This is the most important example in this. Patient is not breathing. Even though in exam, nobody is going to give this kind of terminology like patient is not breathing. But let us assume you have an alveoli and you have a capillary and you have a barrier again. So how many ever times I draw, like Captain America, I can do this all day. Clear? I can keep drawing this any number of times, n number of times. But anyways, so this is very important diagram, that's why. So let us assume patient is not breathing. I told you patient not breathing means they are actually hypoventilating. Due to some reason he is not breathing properly, hypoventilating. I told you one gas that is going to be affected maximally, obviously oxygen will be affected, I am not telling no. One gas that is going to be affected maximally is carbon dioxide, because carbon dioxide solely depends on ventilation. Since the patient doesn't ventilate, like this carbon dioxide that is accumulating in the alveoli cannot move out, and there will be so much of carbon dioxide that will be accumulating within the alveoli. And after some time, because you have something called a gradient, it works with a gradient, because the carbon dioxide gradient here is low and here is concentration here is high. It moves from normally from blood to the alveoli. But what happens is here the carbon dioxide concentration is now increasing. By your same Fick's law, now the movement of carbon dioxide also will stop and your carbon dioxide will start accumulating in the blood as well. So which means this patient will have raised PaCO2, and that is the reason why any patient who is hyperventilating, you are going to have a high PaCO2 level. Clear? Increased PaCO2. So this increased PaCO2 has a lot of impact. So this is going to reduce the PaO2. This is definitely going to reduce the PaO2. How? By two reasons. One reason already told you, patient is not breathing means he is not only exhaling carbon dioxide, his movement of oxygen into the lung is also reduced, which means his movement of oxygen into the lung is also reduced because he is not breathing. Number one. Same mechanism. Understand? Similarly, whatever oxygen is coming inside, it is getting diluted so much with the carbon dioxide around. So normally I told you concentration is approximately 14%. Normally what is the oxygen that reaches the alveoli, but here it will become 5 or 4% because so much of carbon dioxide there around, which is not getting exhaled. So which means effective is the PaO2 will be decreased dramatically. Because the PaO2 is decreased dramatically, even though your diffusion barrier is functioning properly, because the patient is not breathing and the alveolar oxygen is reducing, your partial pressure of arterial oxygen is also reducing. So the second most important reason for this hypoxemia with normal A gradient is patient not breathing. But you don't call it as patient not breathing, you call it by a sophisticated name called alveolar hypoventilation. And this is the most important reason for a type 2 respiratory failure, which we'll discuss later on, where you have a low PaO2 because of the high PaCO2. This is the primary event here, and this low PaO2 is the secondary event. Whereas in type 1 respiratory failure, I told you low PaO2 is the primary event and low PaCO2 acts as secondary event in response to the low PaO2 because of hyperventilation. But here, increased PaO2 is the primary event because the patient is not breathing. That is the primary reason. Because of that, your PaO2 also will be low because of all the reasons, explain mechanisms which I told you. Clear? This is what we refer to as alveolar hypoventilation. Whenever you call alveolar hypoventilation, it can be either due to reduced respiratory rate or due to reduced tidal volume. Whenever there is reduced respiratory rate, here the patient is not breathing, which means the patient won't breathe. This typically happens in head injury, opiate poisoning, benzodiazepine poisoning, or like medullary strokes or damage, say tonsillar herniation because of high intracranial pressure or head injury, lot of things. Reduced tidal volume is due to neuromuscular paralysis. Here the patient can't breathe. They want to breathe, but they can't breathe because of the neuromuscular paralysis. Like Guillain-Barré syndrome, amyotrophic lateral sclerosis, many motor neuron disorders, poliomyelitis, especially during acute flaccid paralysis state. Then fatigue of the muscles, lot of reasons. Neuromuscular blocker toxicity, myasthenic crisis, so many examples you can tell where the patient has neuromuscular paralysis because they can't breathe, because they cannot breathe properly and exhale carbon dioxide. Because he cannot exhale carbon dioxide, O2 incoming also is restricted, which means his diffusion barrier is normal, lung is working normally, but his muscles are not working normally or his drive is gone. That is the reason why you are getting this type 2 respiratory failure and alveolar hyperventilation. So in exam, if suppose they tell, what are the causes of hypoxemia with a normal A gradient? You have to tell low FiO2 states or high altitude. Second is alveolar hyperventilation. Don't tell not breathing. Tell a sophisticated name called alveolar hyperventilation. So these are the only two reasons that you have to remember for exam. That is about hypoxemia with a normal A gradient. I think this makes sense, right? So let us see some example of how you affect the A gradient, because we are going to discuss in detail about this A gradient in your arterial blood gas. ABG, when you are going to discuss, we are going to discuss in and out about the A gradient. But right now, let us see how to calculate the A gradient. So first, remember, most important thing, you have to know that this is determined by alveolar gas equation. And very often you find out all these things, but you fail to subtract this, PaO2, and you will get a very huge values. That is very important. So let us assume how to find out the A gradient. So in this example, let me consider a very normal patient, like who's having maybe a 40-year-old man. Weight of 70 kilograms. This doesn't mean anything to me. Just I'm giving for confusing you in exams. So here is PaO2, arterial oxygen, is approximately around 95 millimeters of mercury, and this carbon dioxide levels are probably around 40 millimeters of mercury. Absolutely normal patient. There is no doubt about that. And is breathing normally, and I want to know the A gradient. And is breathing room air at sea level. Obviously, you have to assume these patients are at sea level, even if they don't give an exam. Unless until they give a high altitude, you have to change the entire formula. Otherwise, there is no need. So what I'm trying to tell is, as per the alveolar gas equation, because he is at sea level and breathing room air, it will be like 713 into 21 by 100, that is FiO2, minus PaCO2 is 15 divided by 0.8. First, what I'm going to tell, 713 into, sorry, it's not 50, it is 40. Sorry for that. So this is 40 by 0.8. So 713 into 21 by 100, it's going to be somewhere around 149 point something. So it will be 150 I can take, minus 40 by 0.8 is 50. So I'm going to tell it is 100 millimeters of mercury. Remember, you have found only the PaO2. You have not yet found out the A gradient yet, which means this must be minused with the partial pressure of arterial oxygen, which is clearly given here in the ABG analysis, that is 95 millimeters of mercury. So which is equivalent to 5 millimeters of mercury, which is still definitely less than 12, which is a normal A gradient. So this patient is having a normal A gradient, without a doubt. This is a normal patient. Clear? Like this, this is only an example. We'll see more calculations of A gradient in our ABG problems. But right now, this is how you calculate the A gradient. So, understand it. So the A gradient will tell you the wastage. At the same time, it also helps you to find out the type of the respiratory failure. Increased A gradient always goes towards a type 1 respiratory failure, whereas hypoxemia, the normal A gradient, always goes towards a alveolar hyperventilation, that is a type 2 respiratory failure or a low FiO2 states. As simple as that. Now we have understood. So the entire essence of understanding all this A gradient and all these things is not complete unless until you understand the high altitude related problems. So now we are going to the physiology of the high altitude, and also the pathology of the high altitude also. Not only the physiology of high altitude, we are going to see the pathology of the high altitude as well. So what is the main problem in the high altitude? It's the low PaO2. That's it. This is the main culprit for the problems in the high altitude. How you achieve this low PaO2? Very simple. Because the atmospheric pressure is dropping, barometric pressure in the high altitude is dropping. Because of that, you have a low partial pressure of alveolar oxygen. Because of that, your arterial oxygen partial pressure is also dropping. Since both are dropping and actually the lung is functioning normally, so these patients will have a typically normal A gradient. So there is no problem. A gradient will be normal, but actually the patient is having hypoxemia. What are the things to counteract this hypoxemia? Suppose if I ask you what are the things that can typically counteract this hypoxemia, there are a lot of mechanisms that your body tries to overcome the hypoxemia. The first thing the body tries to do is, in response to hypoxemia, is initial response. The first response, the moment you go to the high altitude, the moment you experience this hypoxemia first, your body is trying to activate the peripheral chemoreceptors. This low oxygen itself will activate the peripheral chemoreceptors. Please do remember, the central, I shall discuss later on, the central chemoreceptors are not going to sense your hypoxemia. Oxygen cannot be sensed by your central chemoreceptors. Only peripheral chemoreceptors can sense this hypoxemia. They will be sensed by peripheral chemoreceptors and they are going to increase the respiratory drive. Why you are increasing the respiratory drive? This is in an attempt to normalize this PaO2. This is an attempt to normalize. The body is trying to normalize the oxygen by at least taking in more air and more oxygen. So that's what body is trying to do. But one problem also comes along with it. This increased respiratory drive is going to reduce the PaCO2 levels. Obviously, I told you by a lot of ventilation based examples in the Fick's equation itself, the solubility coefficient, definitely the moment you increase the respiratory rate and respiratory drive, your PaCO2 will drop. What is the problem in that? The problem in that is this low PaCO2 is going to inhibit this respiratory drive, which means initially as a first step your body is trying to normalize, but in the second step this reduction in the PaCO2 is going to inhibit your respiratory drive so that your attempt to normalize this PaO2 will not happen and the total mechanism will go for failure. Clear not? So this is what is done. Why is low PaCO2 is going to inhibit your respiratory drive, which means I am telling you more than the oxygen, your respiratory drive is totally dependent on the PaCO2 levels. Your carbon dioxide is the one that is going to determine your respiratory drive in the first place. This is a very important concept again. So how your carbon dioxide is going to determine the respiratory drive? That is again based on the brain and the chemoreceptor function. But very importantly, your respiratory drive is completely dependent on the carbon dioxide. So this can explain a lot of things. For example, if you ask me what is something called a CO2 reserve, there is something called a CO2 reserve which is very important for understanding your obstructive sleep apnea and all. At the same time, you have something called a breath holding threshold, and you have a lot of things to be understood. For example, and you have something called apnea threshold also. So let us take a subconscious or an unconscious patient. We are not talking about a conscious patient who can voluntarily hyperventilate. At a subconscious level, when you are not in your senses to breathe by yourself, which means right now I am talking to you and I am not knowing that I am breathing consciously. I am breathing by my autonomic nervous system, which is automatically happening. I am not thinking every time I have to breathe in and breathe out. So in that condition, I am not talking about voluntarily. Voluntarily I can hold for some time, voluntarily I can hyperventilate also for some time. So let me assume I am not doing any voluntary things. Subconsciously, that is autonomically I am doing things. In that, what will be the value below which you can't breathe, which means the breathing will stop. That is 32. Below this 32, you will not breathe and you will actually go for apnea. Clear? This is what we refer to as apnea threshold. This 32 millimeters of mercury. Normal carbon dioxide is 36 to 44, but this 30 millimeter average is 40. 40 is the normal carbon dioxide, average in majority of the patients. But this 32 less than 32, we call it as a apnea threshold. Clear? And similarly, what is the ideal carbon dioxide? Ideal carbon dioxide is 40. This 40 is said to be something called, this 40 millimeters of mercury is what we refer to as something called eupnea threshold. Eupnea threshold, which means below 32, your respiratory drive is lost. There is no respiratory drive. I am talking about, when you are breathing involuntarily, not voluntarily. When you are voluntarily hyperventilating, you can wash out the carbon dioxide to even less than 20, to less than 25, 22 also. I am not talking about that. But involuntarily, when you are breathing like what you do it normally day by day, less than 32, obviously will stop the respiratory drive and it will go for apnea. You will not breathe anymore. Typically, similarly, this is called eupnea threshold. Why it is? Because your body's attempt is to maintain this CO2 at the 40 level only. So this gap between this 32 and 40, this is what we refer to as something called a CO2 reserve. This is what we refer to as something called a carbon dioxide reserve. What is the importance of this carbon dioxide reserve? Let us see. What is the importance of this carbon dioxide reserve? Because you breathe, your entire respiratory drive shuttles between this 32 and 40 only, which means the more you go towards 32, your respiratory drive will decrease. The more you go towards 40, your respiratory drive will increase. And if you go beyond 40, there will be significant increase in the respiratory drive. Again, what is the importance of that? So let us assume I'm going to breath hold for some time. I mean, it depends on the time. Here I didn't do it properly, so my time was very less. But anyways, there is a point that is called a breaking point where you cannot hold your breath anymore. Why? Because at one point, because I'm not breathing, the CO2 accumulation will keep on increasing, and at one point the CO2 levels will be so high that will break my voluntary control and will start breathing. And for a very brief time, I will be actually hyperventilating. Why? Because from this particular higher value, I have to come again back to the eupneic level, that is 40. That is where it should be maintained. So what is the breath holding break point threshold? That is 50 millimeters of mercury. Most of the time, this is the threshold. This is the breath holding threshold. You can voluntarily hold breath till your PCO2 reaches 50. Beyond that, your respiratory drive driven by PCO2 will be so much that will break your voluntary control of breath holding. That is the reason why nobody can die by voluntarily controlling their own breath. Because the drive will become so high, you will somehow start breathing again, and you will definitely hyperventilate for a variable period of time to bring back your PCO2 back to the eupneic level, that is 40. So which means what you are trying to do is you are trying to breathe in this narrow range of 32 to 40, and this is where your respiratory drive keeps shuttling. The more you go towards 32, your respiratory drive will decrease. The moment you go above 40, your respiratory drive will increase. So you are maintaining at a eupneic threshold of 40. So in this, clearly you can see, the more, your PCO2 drops, you are going to reduce the respiratory drive. So that is what happening here. Because in the high altitude, because this hypoxemia reduces the PCO2 because you are hyperventilating, it is going to inhibit the respiratory drive. And your initial mechanism number one's attempt to normalize the PaO2 fails miserably, because this low PaCO2 will not allow the PaO2 to normalize, because your respiratory drive will be lost. Clear? So which means you have to find a way in high altitude, which means this is not something permanent. Initially this happens. Initially there are two opposing events that is happening. You are trying to hyperventilate, but when you are hyperventilating simultaneously, your PaCO2 will drop. That will prevent your hyperventilation, and PaO2 will never be normalized. So initially you will have a lot of problems because of high altitude. Your PaO2 cannot be normalized at all. It will be low only. So somehow your PaO2 will be normalized. Otherwise, you will result in a lot of problems, which I am going to discuss in the next, within some few minutes. So how can you break this? How can you make the PaO2 normalize? It's very simple. So that is what we refer to as something called early acclimatization. Early acclimatization. What do you mean by in the early phases? What do you mean by early acclimatization? Which means somehow you should break this, PaCO2 from inhibiting the respiratory drive, which means you have to hyperventilate to keep the PaO2 in the normal range. And you have to prevent this PaCO2, low PaCO2 from blocking the respiratory drive. How do you do that? How PaCO2? First, you have to understand this mechanism. How this PaCO2 is blocking the respiratory drive, is inhibiting this respiratory drive, low PaCO2. See, whenever PaCO2 is there, the sensing mechanism is through H plus only, because you know that CO2 with the help of water and with the help of an enzyme called carbonic anhydrase, they are going to form H2CO3, which immediately breaks to form H plus and HCO3 minus. Clear? This H plus is the one that is directed by the brain and many of the chemoreceptors. That is the magic compound, this CO2s indirectly sensed as H plus only. So suppose whenever the CO2 is low, this H plus is low, and this H plus is the one that is sensed by the central chemoreceptors, and that is the one that is actually reducing the respiratory drive. Which means the sense of, CO2 is actually sensed, but what is the actual molecule that is sensed in the form of CO2 is this H plus. And this H plus reduction is the one that is going to reduce the respiratory drive in the brain, and this H plus reduction is due to the low CO2 in the blood. Clear? But if you find a way so that you can bypass this and you can increase the H plus, which means even in the presence of low CO2, if you have found a way to increase this hydrogen ions, you can actually maintain the respiratory drive which means you can hyperventilate. You can hyperventilate and you can normalize the PaO2. Clear? So, in what way your body tries to increase the H+? That is called acclimatization. You have to find a way to increase these H+ ions in the body so that you can, this is a way to fool this carbon dioxide. Even though carbon dioxide is low, still you will increase the H+ so that the brain will think like there is okay carbon dioxide. The loss of carbon dioxide will not be sensed by the brain because the H+ is actually high. How you can fool that? So this is called early acclimatization and it comes from the kidney. It kicks on approximately by 40 to 72 hours and acclimatization will be complete by 96 hours most of the time. So this is the time period for kidney's acclimatization. The kidney will wash out carbon dioxide, bicarbonate. It's going to wash out bicarbonate. Whenever you wash out bicarbonate, it is like you are conserving H+ in the body. So you're going to increase the H+ in the body. So what I told you, low PaCO2 is the one that is reducing suppressing the respiratory drive. Clear? But here, what kidney is doing, how it is sensed, this low PaCO2 is by sensing the low H+. But here, what the kidney is trying to do is, kidney is trying to fool the brain by artificially increasing the H+ by washing out this bicarbonate out of the body through the urine, by carbonic anhydrase mechanism, obviously. So the moment you increase the H+, the brain will think there is sufficient CO2. It will not know that the CO2 levels are actually low and your respiratory drive will be maintained and the respiratory drive will not get inhibited. And now the patient will happily hyperventilate and he can normalize the PaO2. The moment he hyperventilates, even though he washes out the PaCO2, even though he washes out carbon dioxide, that will not inhibit the respiratory drive because of the kidney's action and he can normalize the PaO2. He can happily hyperventilate. Clear? So this is the early acclimatization and the symptoms of low PaO2, which I'll tell you in some time what are the symptoms of low PaO2 and all those things will start resolving. So this is what we refer to as early acclimatization. That is by kidney's mechanism of wasting bicarbonate and conserving more H+. So what compound can mimic this principle? Very simple, it's acetazolamide. Acetazolamide is a compound that is going to absolutely mimic this principle because acetazolamide we'll discuss in detail in nephrology section, but still acetazolamide is one compound that is going to waste bicarbonate and it's going to increase the H+ in the body, which means acetazolamide is going to trigger acidosis by conserving H+, which means it is the same thing like what kidney does during acclimatization. So which means if I take an acetazolamide tablet, before going into the high altitude, I'm having a mountain trekking, and before going into the trekking itself, I'm taking acetazolamide means I can actually prevent the symptoms of early symptoms at least due to the low PaO2. I will normalize the PaO2 without losing the respiratory drive and I can happily hyperventilate, no problem, and I will not be wasting any time, which means acetazolamide is one drug. If you are to wait for physiologically kidney to take over, it needs 3 to 4 days or at least 2 to 3 days minimum. But if you take acetazolamide before going into the mountain, which means the moment you enter the mountain itself, that time itself will already be acclimatized because your body's H+ is already high. So that is why acetazolamide is one drug that is helpful for early acclimatization, and that is the reason why many doctors, especially when the patient asks, I want to avoid the symptoms due to mountain sickness, they give acetazolamide tablet before starting to the mountain trip itself, which means you acclimatize in the ground itself before going into the mountain. So you don't get that initial symptoms of low PaO2. Clear? So this is what we refer to as early acclimatization. Very, very important concept. Clear? This is the first response to your low PaO2. Okay, clear. So this is called acclimatization. But suppose if I am trying to stay in the mountain for a longer time, maybe I am not willing to come down. I've got a good job in the mountain now, the same hilly area. Now I wanted to stay there. So now the principal source of how I maintain this PaO2 in the normal range and prevent the symptoms of mountain sickness is by hyperventilating. But I cannot keep on hyperventilating for longer time. So that is the reason why if you are deciding to stay in a longer time, you will encounter something called a chronic acclimatization or a late acclimatization. These are late responses. Chronic acclimatization is to prevent this hyperventilation. How can you prevent this hyperventilation? I mean, if you stop the hyperventilation, your PaO2 will drop. But how you can maintain the normal PaO2 also, normal oxygen in the blood also, at the same time, you can prevent the hyperventilation also. In what way? So, first thing, you have to increase the oxygen carrying capacity in the blood. Oxygen carrying capacity in the blood. So, how you can increase the oxygen carrying capacity in the blood? By producing a polycythemic response, because chronic hypoxia is going to trigger your erythropoietin release, and definitely you are going to result in polycythemic response. Your hemoglobin will definitely increase. That increases the oxygen carrying capacity of the blood, which might in the future to an extent can reduce the hyperventilation and related early acclimatization response, because I cannot keep on hyperventilating for a long time. Typically, I have to increase the oxygen release to the tissues to prevent hypoxia, because already I am in a low PaO2 state. Definitely I have to increase the oxygen release to the tissues so that no problem happens. So this is by increasing the 2-3 BPG responses. So in a high altitude patient, definitely 2-3 BPG will be very high. At the same time, with a little bit low oxygen itself, I have to maintain a normal ATP production. How it is possible? By increasing the number of mitochondria. By increasing the number of mitochondria within the cells, I can produce more ATP with little oxygen that is available. This is also one response in the cell. And second, next important thing is I can increase the angiogenesis, which means I can produce new vessels in the body. Once I'm going to produce new vessels in the system, I can again increase the amount of blood and oxygen that is going into the tissue. So these are the usual responses that you encounter during chronic acclimatization. Again, remember, it all depends on the altitude. See, acclimatization doesn't mean all this. To an extent you can prevent. It doesn't mean that you go to 20,000 feet and you expect acclimatization to happen. Not possible. Clear? Or you go to the top of Mount Everest and go to International Space Station and expect acclimatization from the body. Everything has a physiological limit. To an extent they can acclimatize up to certain altitude, but beyond that, dramatic drops in the PaO2 will kill you for sure. Okay. Now we saw the acclimatization responses, but you have actually not yet seen what are the problems due to low PaO2. Remember, the problems due to low PaO2 can be multifold. Remember, it can be resulting only in milder symptoms, which is what we call as something called acute mountain sickness. It's a milder form of the disease. Or you can get in very severe illnesses, severe diseases, like you have something called high altitude pulmonary edema or high altitude cerebral edema. Remember, all are same disease only, but the central pathophysiology is low PaO2. Whether you get milder disease or severe disease, all depends on certain risk factors. Remember, the most important is how much PaO2 is dropping. That's the most important thing that will determine whether you'll get a milder sickness or a, major disease like high altitude pulmonary edema and high altitude cerebral edema. Because again, this PaO2 drop will depend on how much altitude you are traveling. How much altitude you are traveling, number one. That's why I told you, if you go to the International Space Station, you cannot expect the body to acclimatize, you will die instantaneously. Number one. Number two, typically rate of ascent, which means how fast you are allowing the body to acclimatize. Rate of ascent is also very important. Number three, your fitness. The more the altitude, more is the risk for severe disease. Similarly, the more faster you go, more is the risk of, because you are not allowing the body to acclimatize, and again you are going to result in severe forms of the disease. Similarly, fitness also is one thing that is going to affect your development of disease in the first place. I mean, any form of disease. I mean, you won't believe if I tell reduced fitness is associated with increased risk. I mean, increased fitness is associated with increased risk of mountain sickness, both acute as well as severe forms. This is a paradox actually. I mean, everyone will think like reduced fitness means more incidence of mountain sickness. Actually, no, it's the increased fitness. More the fit you are, more you are prone for developing these symptoms of acute mountain sickness. And severe disease like high altitude pulmonary edema and high altitude cerebral edema. Probably because your body, if you are fit, you need more oxygen. I mean, it's very difficult to thrive at immediate low oxygen because you are having very fit body, lot of muscles. Probably it's because you need a lot of oxygen all the time. Suddenly, if you are exposed to low oxygen kind of environment, it's very difficult to acclimatize to that. So probably that is the reason. But anyway, these two are the major things that is going to determine your, whether you get a severe disease or mild disease, or whether you get a disease in the first place. All these things, these two are the most important things. Clear? So how this low PaO2 is going to cause this acute mountain sickness and all these things. So I mean, how much altitude? So for example, high altitude illness, let me tell you, high altitude illness typically happens if you are going to cross this 2000 meter mark, that is 8,200 feet. The moment you cross this, 2000 meter or 8200 feet mark, it's very difficult to be without symptoms. Some form of mountain sickness will resolve. So the risk increases when you cross 2000 meters of altitude, 8000 feet. Again, the rate of descent, rate of ascent, especially when you go, like beyond this 2000 meters. After this, if you're planning to go beyond this 2000 meters, the rate of ascent, there should be a rule actually. So where it's important to ascend, go to high altitude at less than 1000 feet per day, which means the recommended ascent is only 1000 feet per day. And with every third day, you have to give something called ascent holiday. Every third day, you have to give ascent holiday, which means beyond 2000 meters. That's what I'm telling. Beyond 2000 meters, if you're going up, so you can go 1000 feet per day for 2 days. Then after that, again give an ascent holiday on the third day, and again try to move for the fourth day once again. So this is what is the recommended limit. If you exceed this after 2000 meters, if you go at the rate of more rate like 2000, 3000 feet per day, again you are prone for getting acute mountain sickness and even severe forms of disease like high altitude pulmonary edema and high altitude cerebral edema. All these things are very, very important. And typically fourth one that determines the mountain sickness is history of high altitude sickness already. Prior history of high altitude sickness means you are prone for high altitude sickness in the next time also. So this is also very important. Remember, acute mountain sickness or this high altitude related sickness is different from your motion sickness. Motion sickness is due to vestibular apparatus problem. High altitude sickness is due to low PaO2. Don't confuse with them. Mountain sickness you will treat with your anticholinergics like your scopolamine patch and all, hyoscine, scopolamine and all. So this is how you treat the motion sickness. But mountain sickness you are going to treat in a very, very different way. High altitude sickness should be treated in an extremely different way, not like what you are going to treat it routinely. Okay. So how you are going to result in problems in the first place? Okay. Now let us see. Whenever you have a low PaO2, there are two things that are going to happen. The first thing, you are going to get something called hypoxic pulmonary vasoconstriction. This happens in the lungs. This mechanism of hypoxic pulmonary vasoconstriction is also called as Euler-Liljestrand mechanism. And this will also lead to vasodilation in many other areas. This will also lead to vasodilation in many other areas. Remember, this is a very important concept to understand. Remember, your hypoxia will result in hypoxemia and hypoxia will result in vasodilation of all the areas in the body except the lungs, which goes for vasoconstriction. The reason which I will tell you in some time. But they are the only areas which go for vasoconstriction. Okay. Especially what area vasodilation is very important, that is cerebral vasodilation is too important to understand. So that is the most important area I need. Okay. So why you get this hypoxic pulmonary vasodilation? Physiology wise, it's very important to understand this mechanism. Let us say two alveoli. This is a normal physiological thing, that hypoxic pulmonary vasoconstriction. Let us assume this is the pulmonary artery that is supplying these two alveoli, and these are the pulmonary capillaries. For understanding, I am telling. And finally, this forms the oxygenated blood, that is the pulmonary veins, and reaches the left side of the heart. And this is from the right side of the heart, which carries the deoxygenated blood. But let us assume due to some reason this alveoli is not functional. Very, very poor ventilation or no ventilation at all is happening in this alveoli. Which means, suppose if you don't do anything, this deoxygenated blood will travel through the alveoli, and if nothing happens, they will travel to the other side and they will actually mix with this oxygenated blood, and they are going to produce, something called mixing air. This oxygen and deoxygenated blood will mix because here there is no ventilation going on. So finally, you will result in this principle of mixing the oxygenated blood with the deoxygenated blood is what we call as shunt formation. Clear? The moment you start forming the shunt, the moment you produce these shunts, you will going to result in VQ mismatching. So this is typically, you are going to result in severe VQ mismatch, and you are going to result in more and more hypoxemia. And this form of shunt is what we refer to as something called a physiological shunt, not an anatomical shunt. So anatomical shunt, where an anatomical defect anatomically forces the deoxygenated blood to mix with the oxygenated blood, like TOF, transposition of great vessels, truncus arteries, a lot of congenital conditions are there. But actually physiological shunts are more common than anatomical shunts. This is what is going to happen. So to prevent this, lungs have a protective mechanism. That is what we refer to as something called a hypoxic pulmonary vasoconstriction. So this is made by something called hypoxia-sensitive potassium channels, which opens up and causes depolarization, and it's going to result in, calcium influx and vasoconstriction and so on. So we'll discuss the mechanism later on. But anyways, this is what we refer to as something called hypoxic pulmonary vasoconstriction. And this is a very important protective mechanism. Now what is happening is, instead of the blood moving to this side, that will not happen because of the very high resistance in this circuit, because of the vasoconstriction. They will not allow the blood to move to that area. Instead, the blood will start moving excessively into this alveoli that is normally functioning, which means all this will try to get oxygenated, and the mixing is avoided as much as possible by this mechanism. Since the mixing is avoided, you are trying to reduce the VQ mismatch, ventilation perfusion mismatch, which means you are trying to reduce the hypoxemia. In simpler terms, you can tell this hypoxic pulmonary vasoconstriction reduces the mixing, and it avoids the physiological shunting, and it avoids the VQ mismatching, and to an extent they can avoid the hypoxemia. So which means it's a natural mechanism, a normal mechanism in the lung, hypoxic pulmonary vasoconstriction. But this becomes a villain in the high altitude. In the high altitude, what happens is, because universally there is hypoxemia, not only this particular alveoli, even every single alveoli is going to go for hypoxemia, which means the lungs will get confused. Lot of areas in the lungs will go for hypoxic pulmonary vasoconstriction, and few alveoli with vessels that will not go for hypoxic pulmonary, because it's a non-uniform process. And very important thing, hypoxic pulmonary vasoconstriction, one more important point is, this is a non-uniform process. Since it's a non-uniform process, there are certain alveoli that will go for, vasoconstriction, and there are certain areas of the lung which will not be vasoconstricted because it's a non-uniform process. And lot of blood, because so much of alveoli are going for actually vasoconstriction, and some are actually not going for vasoconstriction, the blood will be actually diverted towards the alveoli which are not going for vasoconstriction. And these areas which are having high blood flows, at the same time you are having high pulmonary vascular resistance, will result in exudation and all. Because of a high hydrostatic pressures in the alveoli, they will go for fluid exudation, and they can even go for pulmonary edema. Clear? So this hypoxic pulmonary vasoconstriction can produce a symptom called acute mountain sickness, which is nothing but mild symptoms. So initially what they will have is, they will just have some exercise intolerance. That is because of the low blood flow across the pulmonary vasculature and reaching the left side of the heart. Because low blood is reaching the left side of the heart, you will get simply something called a exercise intolerance. You will get something called a exercise intolerance. Clear? Next thing, it can even result in a severe disease. You can even result in a severe disease. Exercise intolerance, and typically they will experience a feeling of dyspnea. That is what is more important, and that is due to the activation of the J receptor. This mild symptoms is due to typically J receptor activation, and that's also one reason why you get this exercise intolerance. Leave that. Anyway, this is the most important thing you will get. You cannot walk, you will feel fatigue very fast. If it's a severe disease, that is what we refer to as something called high altitude pulmonary edema, where typically patient will start developing severe shortness of breath. At the same time, patient will start getting cough, hemoptysis. Okay, patient is going to get cough, hemoptysis, and maybe patient even go for cyanosis. So this is a severe disease. This is what we refer to as high altitude pulmonary edema. You can see this high altitude pulmonary edema in lot of Hollywood movies. If you take, for example, one of my favorite movies is Vertical Limit, where you can see people who get stuck in the Everest at certain altitude, especially in high altitude. They tend to cough out blood actually, that they are shown. That's typical of high altitude pulmonary edema. That's a very good movie to watch. Anyway, so you have this severe disease in the form of high altitude pulmonary edema. Then what is the problem with cerebral vasodilation? This cerebral vasodilation is going to increase the blood flow to the cerebellum, brain. This increased blood flow to the brain because of cerebral vasodilation is going to increase the ICP, and you are going to get symptoms of raised ICP. Initially, in acute mountain sickness, you will get only mild symptoms like nausea and vomiting, headache. Again, this vomiting is not due to your vestibular problem. That is motion sickness. This is mountain sickness. Even after stopping the moving thing, you will still feel severe vomiting. Okay, so this is what is going to happen, acute mountain sickness. But in severe disease, suppose if the patient experiences a severe disease, that is what we refer to something called a high altitude cerebral edema. So in those conditions, apart from this headache and nausea, you will also start experiencing a altered mental status. That is altered sensorium. You will get altered mental status. Along with altered mental status, you will start experiencing patient may even become low GCS. Their Glasgow Coma Scale score might reduce. Patient may even go for a coma. Even they can go for seizures also. That is because of dramatically raised ICP, because of very high blood flow. This is a severe disease called as high altitude cerebral edema. But all this, the primary culprit is your low PaO2 only. Do you understand? So this is the reason why you have to treat these disorders also. How you are going to treat these disorders? Number one, treatment. Suppose if it's a mild disease, that is called acute mountain sickness, where you are going to experience only exercise intolerance and you are going to experience your headache, slight nausea and all these things. So this is the mild form of the disease called acute mountain sickness. So if it's a mild form of the disease called acute mountain sickness, it's only supportive treatment is needed in the form of hydration, a good hydration, maybe analgesics like paracetamol or all these things. Plus or minus you can use astazolamide to provide early acclimatization. Plus or minus you can give astazolamide for early acclimatization. But anyway, this itself is more than enough, because in 40 to 70 hours, you know, the low PaO2 will be corrected. All the symptoms are due to low PaO2 and this will be corrected within, if it's mild means it will be corrected within 40 to 72 hours. I told you, once the kidney kicks in. Kidney compensation will kick in and it will increase the H plus in the body, which will prevent the loss of respiratory drive, and you can hyperventilate and you can normalize the PaO2 so that all the symptoms will resolve within a period of 2 to 3 days max. After this, suppose if you are encountering a severe disease, like for example, if you have a high altitude pulmonary edema or a high altitude cerebral edema, you have to be, now it is not like supportive or anything, it should be very serious now. So the patient might die. So in this condition, the most important treatment is rapid descent. The most important treatment. Rapid descent. This is the most important treatment for any severe disease, severe forms of high altitude illness. You have to immediately pull the patient down. Very, very important, because if you don't, do the descent, and again, that's the primary reason is the patient is in the top of the mountain. That's the most important reason. If you are not going to pull the patient down, as soon as possible, they're going to die. So that's the most important thing. At the same time, you can give supplemental oxygen. This is also a very important form of treatment, in the form of you can give NIVs and all, non-invasive ventilation through mask, where you can correct this PaO2 to an extent by giving supplemental oxygen, so you can avoid this cerebral vasodilation, hypoxic pulmonary vasoconstriction. So to an extent you can, till you come down, you can give supplemental oxygen. Plus or minus, you can use other drugs like astazolamide, which produces acclimatization anyway, but that is not that much useful in this severe form of illness. Plus or minus, you can give your drugs like nifedipine. Remember, nifedipine is typically used for high altitude pulmonary edema, because they reduce the, nifedipine is going to reduce the hypoxic pulmonary vasoconstriction, because they produce pulmonary vasodilation. So to an extent, you can avoid this. Plus or minus, you can use dexamethasone. Remember, dexamethasone you can use for your high altitude cerebral edema. Typically, if you use, maybe used for bar plus or minus high altitude pulmonary edema also, but predominantly we use for high altitude cerebral edema very commonly. Why? Because dexamethasone reduces the edema. Steroids reduce the edema, because the edema what you are going to encounter in high altitude is because whenever you take a cerebral edema, there are two types of cerebral edema are there, which we will discuss in detail when we are going to discuss the CNS section. Cerebral edema is two types. One is called your cytotoxic edema. Second one is called vasogenic edema. Cytotoxic edema is due to cell are swelling with water. Lot of water is inside the cell and the cell gets completely edematous. So let us draw like this. So the cell is normally like this, and now it gets swollen up because of the water influx, because of excessive water that is coming inside. So that is why you get the cytotoxic edema. The best way to treat cytotoxic edema is hyperosmolar agents like mannitol or 3% NaCl. Clear? This is what happens in conditions like stroke, especially ischemic stroke and all. But vasogenic edema is something where a cell is there, where this is the vessel where the exudation happens. exudation, fluid exudation happens and around the cell, around a particular area. So this is what we refer to as vasogenic edema, which means it comes from the vessel, not it is due to like absorption of water by the cell. So this is vasogenic edema. So this typically happens in conditions like high altitude illness, that is high altitude cerebral edema, and it can happen in space occupying lesions, tumors and space occupying lesions. You encounter vasogenic edema only, and the best treatment for vasogenic edema is dexamethasone. Since it's a high altitude cerebral edema, you're going to treat with dexamethasone and not mannitol or 3% ACL, which is not actually that beneficial here, mannitol 3% ACL or not. So these are the treatments you can give, but the most important treatment is the rapid descent. As soon as possible, make the patient come down. So that will be the most important treatment in high altitude illness. Clear? And finally, after knowing all these things, what is the prophylaxis? Prophylaxis, next time when the patient wants to go up, I mean, if there is a previous history of acute mountain sickness, even milder forms, next time if the patient wants to go up, ask them to go gradually. So gradual ascent, point number 1. Second thing, before going itself, please give astazolamide. It will help in faster acclimatization, because the kidney, what kidney does in 40 to 70 hours, astazolamide does immediately in the ground itself before going to the high altitude. And definitely you can use nifedipine or dexamethasone as an optional. This is something controversial, nifedipine or dexamethasone, but still you can try. If the patient has experienced a little bit severe forms in the past, so you can try to, give nifedipine or dexamethasone. Clear? Suppose there is another entity called, these are things that are happening acutely, but there is another thing called chronic mountain sickness. That's called CMS. That's called a chronic mountain sickness. We are going to call it as CMS. So what is going to happen in CMS? Remember, all this acclimatization, even though I told you a lot of acclimatization that happens in, chronic, high altitude exposure. But in certain cases, depending on the high altitude, depending on the body condition, usually remember your altitude and hypoxemia must be balanced by your acclimatization. Your chronic acclimatization, like polycythemia and all these things, your chronic acclimatization should be balancing all this so that it remains in a balance, so that nothing happens to you. But suppose if your altitude is so high or your hypoxemia is so severe for a longer time, which overwhelms your acclimatization process, which means you cannot, this chronic acclimatization is not able to compensate for this altitude exposure. Which means either you are going to a very high altitude or a body condition is not allowing your PaO2 to normalize, which means you might have a lung disease, which might prevent, the PaO2 to rise. A subtle lung disease also, which might cause the PaO2 not to rise to a normal level, which means your acclimatization has failed. This is a failed acclimatization because of various reasons. What will happen in this condition? This will going to result in something called a chronic mountain sickness. And chronic mountain sickness is typically due to hypoxic pulmonary vasoconstriction that is going to happen for a chronic period. This chronic hypoxic pulmonary vasoconstriction is going to increase the pulmonary vascular resistance chronically. Increased pulmonary vascular resistance for a chronic period is what we refer to as something called pulmonary hypertension. It's a reactive pulmonary hypertension. So this pulmonary hypertension is going to result in right ventricular failure, and that is what we call it as cor pulmonale. And this is the reason for death in this patient. Somehow they die after a long time. Suppose if your acclimatization is not counteracting your altitude exposure and the hypoxemia, and still if your long-standing hypoxemia continues and the chronic because it all depends on the altitude. For example, the highest altitude where the humans are known to live is around 5,500 meters. This is present in Himalayas, where some tribe lives there. They are called as actually Red Indians, Red Himalayans. So, these people look very red. Actually, they have a lot of acclimatization process. Like, for example, they will be short in, height because of they live as a generation after generation, they live at that particular altitude. This is the highest altitude where humans are known to live, 5,500 meters in Himalayas. Certain tribe people are there. So, they look actually short. Why their body is short is because this is an evolutionary principle where because of chronic low oxygen exposure, your body surface area should be less because they have to meet the demands of the low oxygen with a small body. Big body cannot meet the demands of a low oxygen there. So they will be shorter in size, and they'll be severely red in color. That's why they're called red Himalayans. Why they are called red? Because they'll be having severe polycythemic response. Their hemoglobin will be in 19, 20, 22 level. So that is the reason why, but we cannot tolerate, because they are having a lot of changes in their genetics itself, in their genes itself, they will have a change, so that they will acclimatize generation after generation. But if you go to the high altitude and all, you will die from chronic mountain sickness. You cannot survive for a long time. So because of the pulmonary hypertension and carpulmonale, you are going to die. So this is the principle of something called a chronic mountain sickness. And again, treatment is going to be bring the patient down as soon as possible, and you have to give supplemental oxygen, and the treatment will be more of a high pulmonary hypertension and right heart failure treatment. Clear? This is all about high altitude sickness. So we have discussed in detail about the hypertension, high altitude exposure in this particular example. So once we have discussed about the high altitude in this particular example, it's also important to note about the other laws that govern the oxygenation. What are the other laws that are going to govern the your oxygenation? We have already discussed about two laws. One, I have told you about the Fick's law for diffusion, and second one, I already discussed the Dalton's law that also governs the oxygenation, because that is the one that determines the partial pressure in a gaseous mixture. Okay. Number 3, you have third law called as something called Henry's law. You have a third law that is called as Henry's law. So what do you mean by Henry's law? Henry's law is telling you that your amount of dissolved gas in a solution is proportional to the partial pressure of the gas. So which means, let us assume a fluid, and the amount of gas, let us assume this green thing is a gas, amount of gas that is dissolved in a solution is equal to the partial pressure of that particular gas. The partial pressure of the gas is the one that will determine the amount of gas dissolved in that solution. Clear? Amount of gas dissolved in the solution determine the partial pressure of the gas, maybe outside the solution. So if you want to express, it is called as concentration is equal to partial pressure into solubility coefficient K, or you can write as K equal to concentration by P, partial pressure of the gas. But anyway, this is Henry's law expression, but this is not needed for exam. Anyways, they're not going to ask unless and until they want to screw you up in exam. But anyways, what is the importance of the Henry's law? The most important disease that is associated with Henry's law is your famous Caisson disease, or otherwise referred to as something called a decompression sickness. You call something called a decompression sickness. This is the one that is going to be associated with your Henry's law predominantly. So what do you mean by this Henry's law, and what is the application? How it's associated with the Caisson's disease? So let us assume there is some amount of dissolved gas in this. Let us assume there is some amount of dissolved gas in this. And let me tell, I am increasing the partial pressure. So initially there is a partial pressure of the same gas, and this is the dissolved gas, D. And now I am trying to increase the partial pressure of the gas. What will happen? By Henry's law, definitely the amount of dissolved gas should increase. As simple as that. Similarly, let me put, there is some partial pressure of the gas, and this is the amount of dissolved gas. Now I am trying to lower the partial pressure of the gas. Now by Henry's law, what should happen? The amount of dissolved gas also should reduce the moment I am going to lower the partial pressure of the gas. So let us assume this is the amount of dissolved gas. If I am trying to lower the partial pressure of the gas, actually I should reduce the amount of dissolved gas in the solution. Clear? Which means the gas is going to go out into the atmosphere. So this is what is going to happen. So how you can apply this to your Caisson disease principle? So remember, this diving is a very important problem, because diving has a lot of implications, literally. So how diving has a lot of implications? Because number one, this is, for example, let us take a sea. Even this disease and all will not happen when you dive in the lake or when you dive in the swimming pool. Even to 10-meter depth of swimming pool or lake, if you dive, this disease will not happen. This disease will happen only if you are going to dive into a sea. So why sea only has a lot of problem? Remember, again, it is based on a very important law called Pascal's law. What Pascal's law is going to tell is the pressure that is applied at one point of the fluid will be equally transmitted to all the parts of the fluid. Which means what is going to happen is a water body, like one water body, because the water are interconnected and locked with each other, a water body acts as a single entity. I mean, you don't believe it. That is true actually. That is the reason why when you go to a tank, the entire tank's water acts as a single body. They are adhered to each other. I mean, because of the Pascal's law. And similarly, a sea also behaves like a single body. For example, an ocean or a sea surface within the tectonic plates, they act as a single body. When you go to a 2-meter depth in a lake, the water column in that lake only is compressing you at a height of 2 meters. When you go to a sea and you go to 2-meter depth, the entire sea and the ocean is actually pressing you at a depth of 2 meters. That is what Pascal's law is telling, which means going into the sea is not the same as diving into a lake or diving into a swimming pool, where it's a small water body. Diving into the sea means at a depth of 2 meters, the entire sea's water at the height of 2 meters is pressing on you, which means the barometric pressure rise under the sea is going to be something unimaginable. You're going to result in so much of high barometric pressures, and that is the reason why especially diving into the sea has special precautions. For example, let us assume a person dives into the sea and goes under the water. Remember, at this particular zone, at this particular area, you can see there is so much of pressure, like the entire, sea's pressure is acting on this patient. Acting on this person, which means the barometric pressure, I don't call atmospheric pressure because the patient is not in the air. I can call the barometric pressure is so high, it might be depending on the depth he is going, depending on the amount of water column that is present above his head, the pressure might rise up to 10, 12, 20 atmospheres as well. So at the depth of the sea, if you go to the bottom of the sea, your pressure might be up to 1,000, 2,000 atmospheres where it will be crushed into the water can, like a water can. So don't go that. Anyway, nobody does that unless until you have a submarine to go. Special precautions. Anyway, so this patient, let us assume they go to a certain depth, maybe 10 meters or 20 meters. So what is going to happen by Henry's law? Your barometric pressure is going to increase, which means the barometric pressure is going to increase and the patient is under the sea now. Now what is going to happen is, in your blood, there are some dissolved gases. When you take inside the blood, there are some dissolved gases are there like nitrogen, and they are normally not going to mix into the blood because of the low solubility. Because Henry's law clearly tells the solubility and the concentration will increase the more you put the pressure. So since the barometric pressure increases, you are going to increase the solubility of nitrogen by just sheer pressure compressing. You are going to increase the solubility of nitrogen, and this nitrogen is going to mix in the blood. And nitrogen is going to enter the blood, and blood will be now containing a lot of nitrogen. Now you don't have any problem at all. Just it's mixing. It's an inert gas. It doesn't produce any reaction in the body. So all right, you'll be completely all right, no problem. But this person suddenly comes out very fast. So now he has come here all of a sudden, swine. So what is going to happen in this particular particular case? Now suddenly you have reduced the barometric pressure. Now the barometric pressure is very high. So the N2 that was mixed in the blood was very high. Suddenly here the barometric pressure dropped dramatically because you are coming to the surface very fast, which means N2 solubility is also going to decrease dramatically, which means all this N2 is going to pop up. I'm telling in the sea, but this is what is going to happen in the blood. It's going to pop out of the blood like air bubbles, because the solubility dramatically drops according to Graham's law because your pressure has dropped. And this popped out nitrogen out of the blood, that is going to go and get locked up in the small capillaries, and is going to cause end organ ischemia and severe organ dysfunction and even possibly death. This is what we refer to as something called a Caisson disease. Clear? To understand this very clearly, you can imagine one important principle. I'll show you one experiment. It's easy to understand. So what experiment I'm going to show is that how can you boil water? How can you boil water? Water can be boiled in two ways, either by heating them. This is something which I should not teach. Everyone knows. By heating and going to 100 degrees C, water boils. By second is exposing to vacuum. You know that? Yes, true. And this is accordance to Henry's law. Actually, water can boil in vacuum. Let us see an example for this. Let us see this video. Let us see this video here. So, where you can see very clearly, I have put a thermometer here. So, what you can see in the thermometer is the temperature, because it should not be fooled, isn't it? So, what I can see in the thermometer is, it is showing 20 degrees Celsius only. That is the temperature over there. So, but what I am trying to do is surrounding this beaker that is containing water, I am trying to decrease the pressure, which means I am connecting to a vacuum generator motor and I am trying to suck out all the air. So, see what happens. If I am keeping on sucking the air, you can clearly see the temperature doesn't change at all. You can see the temperature doesn't change at all by any means, but the water is starting to boil. This is because when I decrease the pressure by producing a vacuum, the amount of dissolved gas will decrease and they will go out of the water. And that is what is simulating as boiling here. Clear? And very, very important principle. So, this is what is causing the boiling here. Do you understand? Clear? So, that is what is going to create the boiling here. Clear? So, literally you can imagine that your nitrogen, if you are going to, come outside, if you come outside very fast, the dissolved nitrogen also is going to boil in exactly similar way. You can even literally the blood boils because of the sudden drop in pressure. The nitrogen that is already dissolved because of high barometric pressure, now suddenly the barometric pressure drops, the nitrogen boils out like what you see in this experiment. So, this is something very difficult to even digest it, isn't it? So, that is why it's important to understand this. So, that is what we call Caisson disease. We have actually basically two types of Caisson disease. One is called type 1 Caisson disease, which is typically mild and you will result only in arthralgia because of the joint involvement. But you can also result in something else called type 2 disease, which is actually a severe disease, where you will result in something called organ failure. That is what we call as type 2 Caisson disease, which typically involves the lungs, brain, joints and the kidney. So, they can go for severe organ failure. Brain will be very worst left and patient will go for coma and they will die. Clear? So, this is severe disease. Remember, in both these conditions, the patient will experience severe joint pain and arthralgia. That is also the one reason the Caisson disease is also called as something called the bends. The bends, because of severe painful joints, the common colloquial name is called the bends. And it can be life-threatening also. Treatment is by hyperbaric oxygen. Hyperbaric oxygen therapy, that's called HBOT, because you have to displace the nitrogen in a non-hazardous way. You have to remove the oxygen out of the lungs by giving hyperbaric oxygen therapy. That is again depending on the Fick's law P1 minus P2 principle. You can actually remove the oxygen out of the system by giving hyperbaric. What do you mean by hyperbaric oxygen? Remember, it is not 100% oxygen. 100% oxygen is not hyperbaric oxygen. Hyperbaric oxygen means you are giving 100% oxygen at very, very high pressures, like 2 or 3 atmospheric pressures. Normally, if you just give 100% oxygen, which means the pressure of inhaled oxygen, partial pressure of inhaled oxygen will be 760 millimeters of mercury, because 100% everything is oxygen. But if you give it hyperbaric, means the same 100% oxygen at 2 to 3 atmospheric pressures you are giving, which means forcibly you are increasing the partial pressure of oxygen to 2000 or 3000. That's what you mean by hyperbaric oxygen therapy. Such high concentration, the lungs will suck the nitrogen out and push the oxygen inside. So that is the idea. Rather than pushing the nitrogen into the microvasculature, you take the nitrogen out of the system through the lungs and exhale it out. So that's what hyperbaric oxygen does. So that's the treatment. So that is what the idea of something called Henry's law is. Apart from the Henry's law, you have other laws also, like for example, you have something called Boyle's law. You know what Boyle's law is? Boyle's law means pressure is inversely proportional to volume in a closed surface. In a closed compartment, pressure is inversely proportional to volume, or you can tell PV must be equal to constant. Pressure volume relationship must be constant. which means it's very simple. When you crush the water bottle, if it's with a closed lid, pressure will increase because the volume is decreasing. When you similarly expand that water bottle with a closed lid, obviously since the volume is expanding, pressure inside will drop. Very simple mechanism. This is what we call Boyle's law, but it should be happening in a closed container, not in the open. Open means it's communicating, means Boyle's law will not apply. So based on the Boyle's law, so many things can be understood. Number one, your ventilator principles is based on Boyle's law only. Your mechanics of breathing is also based on Boyle's law only. And similarly, your diving related illness. This is called scuba related illness. Your diving related illness is also based on Boyle's law only. Typically, two problems you will get because of diving related illness. The most important is the barotrauma. In the barotrauma, the two organs which are closed cavities are going to suffer maximum because of the Boyle's law. One is the lungs, which is a closed cavity, especially the pleural surface. Second one is the, like middle ear. These are the two things that are going to suffer maximally because of the barotrauma. Clear? Because lungs, you will develop pneumothorax. I will always, from here on, I will write PTX, pneumothorax. And middle ear is going to go for tympanic membrane rupture. Tympanic membrane rupture. Clear? All these things are very important to understand. So why, whenever in a scuba, especially, all these things happens when you're diving into the sea, not into the lake or into the swimming pool again, because of a pressure change in sea is too much. I told you so many times already, and I told you the examples in a very, very neat way. So I cannot explain anymore. So pressure change under the sea is something unimaginable. So that's why in the sea it happens, all these things chronically. So let us assume a patient goes down dramatically into the sea, which means your barometric pressure is going to increase. Whenever barometric pressure increases as per the Boyle's law, your volume should decrease, which means all the closed cavities will decrease and it will shrink. Clear? So what are the closed cavities? Your lungs volume will decrease, and your middle ear, again your volume will decrease. But the problem is, suppose in the lungs, if you have a connection with the bulla, let us assume you have a connection with the bulla. What might happen is, sometimes since the lungs are getting compressed, air might be pushed into this bulla. Clear? Bulla also will be compressed, but air might be pushed into this. Many people will have microscopic bulla. Even I might have, you might have, nobody knows. It's not only the COPD patients have bulla, even we have subpleural bulla, which may result in pneumothorax under these special circumstances, conditions like scuba. So where the air will be forced into the bulla. Now suddenly let us assume patient is coming fast, ascent, very faster ascent. Patient is going to ascend very fast. So in this condition, what is going to happen is, suddenly the barometric pressure will drop if he is going to ascend very fast, and the pressure is going to decrease dramatically, which must be associated with increase in the volume, which means suddenly the lungs will expand. At the same time, this bulla also will try to expand. But let us assume this communication of this bulla with the lungs is very, very small. Communication of the bulla to the lungs is very, very small, which means if it is a good communication, then easily that will decompress, because lungs are expanding faster than the bulla. It will easily decompress the, air that is that came in excess during the compression phase, and it will easily decompress and nothing will happen. Suppose if the communication is small, the bulla cannot decompress effectively into the lungs, and they will start expanding. This sudden expansion of the bulla, by simple Boyle's law, because the pressure is dropping, suddenly bulla will expand because of the increase in the volume. Sudden pressure drop, by going up, suddenly the pressure will drop, so the volume will increase, bulla is going to rupture, and they are going to result in the pneumothorax. So this is the thing about the scuba related illness, diving related illness. And the deadliest thing about this pneumothorax is, many times while going down itself, you might have a pneumothorax to an extent, because the air is forced into the bulla sometimes because of the compression of the lung, sometimes air is forced into the bulla. So what might happen is, sometimes the pneumothorax would have formed in the early stages of ascent itself, And it's not only the lung will expand when you come up because of the drop of pressure, the volume will increase. Not only the lung volume will increase, even the pneumothorax volume also will keep on increasing. By the time you reach the surface, you might end up with a tension pneumothorax and you might die on surface. So this is a very, very deadliest thing. Okay, it's not a very simple thing. So you have to be very careful. Again, everything what you have noticed is the Boyle's law. And same happens with the middle ear. So what happens in the middle ear is I told you during diving down, because the barometric pressure is increasing, your volume of the middle ear is decreasing. So what should happen? The moment you are ascending, let us see this thing, you are ascending, the barometric pressure suddenly drops, which means pressure is dropping, which means suddenly the volume of the middle ear also will increase. But this increase in the volume of the middle ear is going to because of the decline in the pressure. This pressure change will be neutralized because the middle ear is in communication with the pharynx through the eustachian tube. Suppose what if this pharynx and the eustachian tube connection is occluded? Because if you have an URI, simple URI, if you have an upper respiratory infection, a sore throat, and you have a nasal congestion, and if you go down, when you come up, this expansion of the volume has to be neutralized. This pressure, because of the expansion of the, pressure change, drop in pressure and the expansion of the volume should be neutralized with the pharynx. And this doesn't happen if you have a URI or a sore throat. So what will happen? Sudden expansion of the middle ear, your sudden pressure drop, and the tympanic membrane will rupture. Once the tympanic membrane ruptures, you might become deaf also. So that's why I told you in scuba related illness, that is the reason why many scuba associated your booklets and all will contain whether you have an URI or not. It's a standard question. Anyone who have gone for scuba will know that you should never lie there. You have a URI or you have a nasal congestion, a pharyngeal congestion, tell them yes, because it's not good to go under the sea. It's not joke actually. It's a little bit dangerous. If you go under the sea, you might even come out deaf. Your tympanic membrane might rupture. It's a very dangerous thing. Don't do that. So this is one thing that you have to understand. So the barotrauma is very common in scuba related illness, especially divers, all this thing. And one important thing the scuba people will teach you, because scuba, they won't allow you to go immediately. They will teach you initially. So what they are going to teach you before, obviously before going to scuba, you have some training session for 1 or 2 days. Then only they will allow you to go into the sea, because the training is really important. What they will teach you, the first thing is, when you come up, never hold the breath. Very important. You should breathe normally. The moment you are ascending up to the surface from the underneath the sea, you should never try to hold your breath. Very, very, very important point. Why you should not hold your breath? Remember, I told you the moment you come up, the pressure will drop and the volume tends to increase. At that time, if you are trying to hold your breath, the expansion of volume will not happen, and I don't know how to explain it, it's going to blast. So not literally, but high risk of pneumothorax. That's why. You're not breathing out also, because the pressure change has to be communicated with the atmosphere, with the surrounding. So I'm not allowing that, and you are stopping by breath holding, and you're coming up, the volume is also expanding, you're not breathing also, everything will accumulate and the chest will expand and you will get a pneumothorax very, very easily. That's why you should never hold your breath when you are trying to come up after scuba diving to the surface. Be very, very clear. These are very important points that you have to know, and these are the applications of the Boyle's law with related to your lung. And this mechanics of breathing and ventilator, we have a special next video which you're going to see in that. And finally, the last but not the least, you have an important law, something called Graham's law. This is not that important for oxygenation. Again, this is based on diffusion. It tells you the rate of diffusion. Diffusion rate is inversely proportional to the molecular weight of the substance. But this is not a very important law. This is true to an extent, but not always. That is why we have everything combined together in the form of something called a Fick's law. This is not that important. Just you have to, in a way, if they ask you can understand, this Graham's law is nothing but the rate of diffusion is inversely proportional to the molecular weight of the diffusing gas. More the molecular weight, obviously lesser will be the rate of diffusion. Lesser the molecular weight, more will be the rate of diffusion. Clear? So this is what we refer to as something called the Graham's law. All these things are very important to understand. So in this video, we have discussed about what oxygenation is. We have discussed about what are the Dalton's law and what are its effects on high altitude. And we have discussed on AA gradient and what is the AA gradient, what do you mean by that, and how to calculate the AA gradient, what is the alveolar gas equation. We also discussed on high altitude related sickness, milder forms like acute mountain sickness, severe forms like high altitude pulmonary edema and cerebral edema, and their treatment and their pathophysiology. and what is acclimatization process, what is chronic mountain sickness, and we also seen the Caisson disease that is based on Henry's law, and we also discussed on what is your like Boyle's law and its related implications in scuba related illness. Clear? The barotrauma. Barotrauma means only two things. In the lung, it is always pneumothorax. In the air, it is always tympanic membrane rupture. Very common after scuba diving. So you have to know all these things. These are the common questions you will get in exam. So with this, I think we can conclude this particular video, which still we have not completed the basics because lung physiology is not something easy to complete. In the next section, we are going to discuss on the ventilation and probably the perfusion related roles of lung.